Good evening. We have with us Dr. Virutam Tomar, pulmonologist, critical care from the Jaswant Rai Multi Super Speciality Hospital in Meerut. We welcome you, Doctor, to the Natco Pharma studio, and we like to listen as to what you're going to tell the young generation of doctors. Those are in the space of critical care and associated with antibacterial resistance. What do you foresee the changes in critical care management?
In India, in last few decades, I am practicing last 30 years in critical care. And what I am seeing that as new therapies are available, like in the rheumatology, MABs we are using rheumatologist persons, the cancer specialty having and bone marrow this therapies, replacement therapies, and other different type of therapies are available. That more and more critical patients are coming up. And as different organ transplants like liver transplant, kidney transplants, and other specialty are working, and newer cardiac transplants, and all these things are coming up, so that the spectrum of the ICU is widening day by day. And side by side, what happening that in the rural practice, or you can say in the subspecialties hospitals, there is a more use of different type of broad spectrum antibiotics, and that I think is a more concern. The reason what we are getting in our patients are most of the time the multi-drug resistant bugs. Even community-acquired pneumonia, if you are getting, that is not responding to routine antibiotics. So what is the reason? I think this is in the community we are getting more these type of antibiotics in our general practitioner in small hospitals. So in future, what I am saying that if we are not stopping these type of use of broad spectrum antibiotics, we have no choice to treat our patients with good antibiotics, and we are losing these patients. We are having very few. We are getting pan resistance antibiotics in the cultures, in the blood cultures, in endotracheal tube sections, and everywhere. Even in the soft tissue cultures, we are getting MDR bugs. This is the reason. But I'm hopeful that newer guidelines. I think Indian government has taken a step to curtail this use of antibiotics in the general practice. I think that will be having some hope that we'll have more good antibiotics or uh, re- no resistance against antibiotics instance.
3 decades of experience. I'm sure you have a lot of advice to the young ICU doctors of the modern or the current era. How do you want them or see them enhance the patient care?
This now the ICU management is a holistic approach. You can't treat individually. There should be an biotogram in the hospital. Every hospital should have a regular cultures in ICU, in the OTs, in the nebulization units. Even doctors and nurses having the regular checkups for the microbiology, what they are growing in the hospital. That is very important. And every step we have to look if our antibiotics are working or not. It's not use left and right use different. With this patient is not responding, so you have to add on one more antibiotic. You should be more of culture based, like this patient is having or now new tools like biofires, etc. I'm not propagating biofire, but yes, the new tools having role and detecting the early detection of antibiotics. Sometimes your patient not suffering from bacteria. It may be fungal, it may be viral. So you have to look holistically that what patients you are dealing, and like very you have to choose these type of drugs, either antiviral, antifungal, or antibacterials, very appropriately in setting of the patient, of which setting of patients you are treating.
Right. My last question to you is: what is the prevalence of carbapenemase producing bacteria in your practice, and which is the best treatment option as per you?
Definitely, I've already said this, we are getting the pan resistance bugs, and carbapenemase are the biggest challenge. So we have to what antibiotics combination. We are newer antibiotics. We are having only the options with avibactam's combination, with ceftazidime combinations, with all these combination which we are having. Even sometimes we have to combine all these polymyxins or the colestins combinations, tigecycline. You have to choose SGNM combinations. You are having which type of this patterns you are getting in your culture, or you have to reconfirm. Sometimes you have the reports, what your microbiologist lab is good, give all these reports or not, and what is your trend. As already said, this is the hospital to hospital based. Every one antibiotic will not work in the another hospital, but definitely is with clinical practice and with the help of microbiologist, intensivist, and all these critical expert, you can choose these type of antibiotics appropriate.
Dr. Tomar, we thank you so much for your time in the studio today and for sharing your valuable insight over the 30 years of experience. I'm sure there'll be a lot for the younger doctors to learn. Thank you.